Hello, I'm Valeria Aoki, a professor of dermatology from the University of São Paulo, Brazil. Thank you for the International Eczema Council for this kind invitation. And we'll be discussing the differences in diagnosis and treatment in the context of ethnic skin. So first topic is to emphasize that the diagnostic criteria for atopic dermatitis still remain attached to the clinical signs and symptoms. They were defined by Hannah and Heike in 1980, and other groups such as the UK Working Party, the Millennium Criteria from the Netherlands, and also the American Academy of Dermatology in 2003, really stressed this clinical signs and symptoms. And what they have all in common is that pruritus is the major symptom, and eczema-type lesions are the main clinical signs for atopic dermatitis. In terms of facial involvement, it's very common in infants. And here I show you 3 infants from our clinic, one from European descendant, Asian descendants, and African descendants. And despite the same geographic topography of those lesions, you can see that the skin of color is different, and the different tones of erythema can be observed. So this is the typical Caucasian pattern, the Asian pattern with brownish tones, and the African pattern with violaceous to grayish tones. There are articles stressing these differences in ethnic skin, and in Asians, scalene lichenification is more prominent, and in patients with skin of color, the erythema may vary from hyperpigmentation with violaceous to gray tones. It's very present. The extensor involvement is also a common feature, and the lichenification is always present and very relevant. An article from Girolamo and collaborators stress the relevance of identifying other clinical phenotypes that are related to atopic dermatitis and are important for making its diagnosis. Those conditions are present in other skin diseases, but they are also present in atopic dermatitis. For instance, nummular eczema, usually associated with Staph aureus infection, prurigo nodularis, which is very frequent in Asian patients, especially in Japan. They account for 30 to 50% of moderate to severe atopic dermatitis. Here you can see those papules, indurated papules, very pruritic and very refractory to treatment. Erythroderma is related to severe atopic dermatitis and present up to 25% of our patients. Lichenoid dermatitis, which is usually associated with African and Asian descendants. The follicular dermatitis accounted for 22% of African patients, and also on follicles. Here are some patients from our clinic. So you can see here an African descent with a very extensive head and neck involvement, severe lichenification, and a very bad complication, folliculitis associated to atopic dermatitis, very hard to treat. Here is another lady from our clinic, again with this extensive lichenification on the face, with this violaceous to grayish color. And look at her inferior limbs, a lot of those papular lesions, a lot of pruritus, and also edema of the limbs. She later developed erysipelas associated to this edema of the inferior limbs. And here is an Asian patient of ours. You can also see the intense lichenification, scaling, and this patient developed later on vitiligo. And look at the head and neck involvement. He had a complication here because she used to work in a factory, and he had later on contact dermatitis on the face due to one of the chemicals. Here is a teenager that has been followed since she was 2 years old. She started with those hypopigmented lesions, some warts here, involvement of the neck, and some months later, she started with an extensive erythroderma. See how infiltrated her face was, the absence of eyebrows and the change of skin color from the brownish African descended skin color to this kind of grayish erythema. And look what happened to her inferior limbs. Look at the dimension here of the lymph node enlargement. So she couldn't walk due to this edema. So she was one of the most refractory patients that we had. The other thing that this article emphasizes is to pay attention to the topography of the lesions. We know that the face is one of the most prominent areas of involvement, but cheilitis is present up to 20% of atopic patients, and sometimes related to Candida albicans when it's angular. The eyelids, especially in Asians, is usually related to severe ocular involvement. So an ophthalmologist is needed to evaluate all those patients, especially those with the eyelid involvement. We see also a lot of nipple involvement, especially in Asians and African descendants. Look at this patient here at her nipples. And also hands and feet involvement. Difficult sometimes to make the diagnosis, but you have to associate with atopic dermatitis clinical signs. Look at these two patients from our clinic. They both have facial involvement with lichenification and scaling. And the patient on the right, besides his atopy history, he started to be very refractory to topical treatment. And look at his lesions close to the perioral region. He had this cercenated borders. So thinking about potential mycosis related to the atopic dermatitis, we requested a KOH that revealed those septate hypha. The microculture revealed microsporin canis. So we have to be aware of other skin diseases related to atopic dermatitis, sometimes inflammatory, sometimes infectious, and usually related to the prolonged use of topical steroids or calcineurin inhibitors. And look at another case from the clinic. This is a 6-month-old African descendant baby who had a past history of mild atopic dermatitis, but then started with those very pruritic papules. The kid could not sleep during the night, and at the dermatological examination, we could see those papules disseminated on the trunk and concentrated here close to the periumbilical region. And when examining his toes, we could see those blisters that were present here. So facing that, at least here in Brazil, we cannot forget about scabies, which is a very relevant diagnosis, and those patients are misdiagnosed as atopic dermatitis patients, or on the reverse, atopic dermatitis patients being diagnosed as scabies. So the treatment option here was sulfur, topical sulfur, 6%, and Vaseline, which is one of the most acceptable topical treatments in those atopic patients. And here I show you those two cases that came very close to our ward. They were referred as severe atopic dermatitis. And one patient had this, both had severe erythroderma, but the patient on the top had also some erosions and those cercenated lesions here. He did not have pruritus, and the patient on the bottom had severe pruritus. So first patient was an endemic pemphigus foliaceus, a very prevalent disease here in my country, in Brazil. So you can see the cleavage here, the subcorneal cleavage plus the campolysis, and also the IgG deposits by direct IF, intercellular stain against desmoglein 1. And here our patient of atopic dermatitis. So erythroderma may be present, but can mislead you in terms of diagnosis. And in terms of treatment, we have here a patient that used one of the first to use topical tacrolimus and see how he improved and see the change of skin of color. And this is another patient with severe facial and neck involvement with methotrexate with good follow-up. And the last point here I would like to stress is how can we trust outcome measures, and EASI proved to be excellent inter-rater reliability if you decide to use a grayscale in clinical trials, and it's a necessary tool. And to finish, are we going to have in the future specific treatments regarding to endotypes and ethnic skin? Probably yes. Even though Th2 is the major response in all ethnics. We know that in Asians, we have a predominance of Th22 and Th17 and less filaggrin mutations. And in African descendants, we have a very high IgE levels interfering with the response. So this will be probably the future of treatment. So thank you very much.